I think that's very good question. So I think easy for us to say, and some of us to say that we have this access to this good resources about an NGS and MRD, but I also do understand that not every place is, even if you wanted to do it, that you might not be able to. So, I think in those settings, I think you make the best of what you can do. If you are able to, if you're from those countries and are able to at least refer to a center who are able to perform either their institutional MRD or able to send the samples to MRD to kind of the third party, I do encourage them to kind of refer patients to those kind of the special ALL specialized treatment centers, which is also true in US too. I know this is kind of global community, but even in the US, that if that you may not, if you see very few ALL patients, and MRD send out may be a burdensome to the institutions or the place, and may not have a logistical in place, and others is more routine because they see hundreds of ALL patients per year, and it's a very routine practice. So I think whenever possible, if you're able to refer and the patients are able to travel, I think it's highly encouraging. At minimum, just for bone marrow biopsy. Some patients have come to our centers just for bone marrow assessment for that reasons for MRD, and they receive their regular cares for chemotherapy or immunotherapy at their close by centers too. So I think it's possible and feasible to refer to. If you don't and are not able to refer, have no access, kind of the those, I think you unfortunately have to make the best decision kind of that you could do kind of at the time. And there's some of the other analysis by flow may not just get to the 10 to minus 4, but close to 10 to minus 3. I think that might be. I think because of that, sometimes in those centers that who are not able to assess MRD are sending patients to bone marrow transplant because you have a no good way of knowing how deep of a response these patients might have gotten. So, but I don't think that's anyone's favorable approach to overtreat or send patients to transplant just because we're not sure that what type of deep response that you did have. So I think whenever possible to consult with kind of the treatment centers, say, specialized centers, I think will be the best approach. And you may not need to do it for every single time point. But I think the critical time point at the end of consolidation, for example, when you're at the fork of a decision making, transplant versus no transplant, or kind of intensifying the care, I think that time point, even if just a one-time referral and consultation, that might be useful and make the critical decision.